So I certainly have the opportunity to present to you another futuristic talk, I guess, to some extent, but actually trying to address another important problem here, how we're addressing the issue of men who do experience erectile dysfunction after radical prostatectomy, and not a new notion. Disclosures. So our objectives here are to present the rationale for invoking the strategies here to enhance the erectile function recovery in men undergoing prostate cancer surgery. And the idea here is what are our possible therapeutic targets and strategies we can consider, where we are now, but also kind of give a sense of where we might be going further forward in the future in this arena. No doubt we all know that ED is a consequence of radical prostatectomy, as you all well know. Historically, this is accepted to be almost a universal outcome in men undergoing the surgery. Certainly with the innovation of nerve-sparing approaches, one of my mentors, Dr. Walsh, and others have made major contributions in how we go about so-called nerve-sparing surgery, which has had impact. We can debate exactly what is the rate of recovery, so I just leave a range there. But I think we all can accept that doing some sort of nerve sparing is better than not doing nerve sparing in hopes of trying to preserve function. And then the thing that's a bit of a challenge for all of us, I think, nowadays, and maybe you all can certainly appreciate this too, is, I've been doing these surgeries for 25 years or more, and the reality is that we've evolved with this surgery. Patients are no longer hospitalized for a week. They're not in the ICU. They're not wiped out for a year. Back then, maybe even with nerve sparing, if their erections took that time to recover, they're still recovering other aspects of their postoperative morbidities. Nowadays, everybody does so well, so early after surgery, there seems to be a disconnect. And in my mind, there's almost a greater demand to try and achieve better outcomes nowadays with regard to erectile function recovery. Now that guys recover fast, they're continent, they're back to activities within weeks to months. Now, mechanisms of erectile function loss after radical prostatectomy include multiple factors, and so certainly being aware of all of this, there have been many investigators in the field who have assembled all of these factors and try to put together nomograms and put together risk factors and all these things. I'm centering here more on the issue of what we're doing surgically and what we can do to try and address that issue of it as we proceed ahead. There are potential mechanisms that we know are related to the neuropraxia, the word that we use for even with doing the very best nerve sparing and the time it takes for guys to recover natural function recovery, as I mentioned, a year or more. Not uncommon, I think. Everybody would kind of echo that. But these may be some of the factors: mechanical trauma, injury to the nerves, even despite attempts for nerve sparing, thermal injury, and so forth. We started to understand more of this on the molecular level, and so I just threw this up there just to say that I've attempted to dissect this with deep dives into the field and try to better understand what are the true pathophysiologic molecular mechanisms that we might exploit here. We understand that the various nerve factors are involved, and understanding mechanisms of nerve healing is, I think, key to getting a better handle on how we might be able to capitalize on that to move forward in new therapies. Work in the field has centered on even mapping out the genes that occur. This is an example of a study with a rat model of cavernous nerve injury that mimics what goes on with radical prostatectomy, with the harvest of nerve structures in the pelvis, running them through the gene microarray studies and trying to characterize what genes go up, what genes go down, what genes we might be able to exploit. So again, this just gives you a glimpse of, I think, kind of the thought process that we might be able to evolve with, even on a gene level, that occurs in the setting of nerve trauma in the pelvis that we may be able to exploit in the future. In my mind, there are basic concepts for preserving erectile function following the surgery. It basically comes down to, can you minimize the dysfunction by doing the surgery as well as we can to least traumatize the vasculature, the nerve structures that are key for penile erection? How do we manage the ED itself in terms of just treatment for those who had pre-existing ED, who have inevitable loss of function, and just what are our current management options to offer just in the lines of ED treatment now? And the reason I harp on this is I want to make sure that we're keen about how we think about the interventions we offer after the surgery and what really constitutes penile rehabilitation. Is it treatment, or is it actually trying to enhance recovery to a level of natural function unassisted by any therapies. And that's a thought behind rehab. Rehab here is our ED interventions, but also in a more futuristic way, are there things that we can do that may actually achieve some level of nerve protection? I'm going to tell you a little bit about that. And what about some things that we think we may be able to do in terms of nerve reconstitution? Now, of course, we're all familiar with the nerve-sparing approach, and this is just one slide in the midst of this 20-minute talk to say that there have been pioneering efforts by many to try and describe how you go about doing the surgery better and better, both with open surgery, robotic surgery, understanding the tissue planes, the infrafascial dissection, high release, antegrade, retrograde dissection. There are different experts out there describing all of these different things. I think all these things are wonderful. I certainly support them, but at the same time, we do not want to compromise cancer control and understand how you go about doing a dissection that achieves that best. So there are various refinements in nerve sparing. We accept all of that. What about just managing ED? This is the process of care model that we, I think, accepted back in the era of the evolution of new oral pharmacotherapy. And this also just gives me just a moment to put up what are our true standard of care interventions based on ease of administration and least invasiveness. You can kind of see how that schema kind of makes sense. And of course, in the past, the idea was always go with the least invasive thing first, see how that goes, go on to the next thing, and so forth, as if, as Dr. Schindel said yesterday, kind of, the kind of rites of passage or walking through the standard therapies that need to be offered. The ED guidelines, of which I was the chair for that, we recently published in the Journal of Urology. The algorithm here, with the point being that using a shared decision making framework, all options can potentially be put on the table for consideration and then can be offered depending upon the scenario of the patient and understanding the discussion of the risk-benefit of the options, preferences and values of the patient, but also then trying to offer just really straight discussion by the clinician, offering some clinical judgment and advice about what can afford that patient the best option. So, and the thing that's been frustrating me for years is that you guys may be aware, certainly in your own practices, that on average it's 8 years for a man who's got ED after radical prostatectomy, who we know is going to have ED, maybe had pre-existing ED or had a non-nerve sparing surgery, to even get to a penile implant when he's requesting it, and studies have shown that. Should we walk through a process of care model with that patient? No, I mean, that patient may be a candidate to say, I'm hearing my options. I want a penile prosthesis. How can we move that person forward? So I think we need to think about, are we doing the best thing to bring the best intervention to get that man to success as rapidly as we can. Brief words about PDE5 inhibitor therapy. And this slide is just meant to say that yes, the PDE5 inhibitors have been successful in the setting of men having ED after radical prostatectomy. There are FDA-approved drugs you can see listed on the slide. The efficacy has shown with many trials compared to placebo. This is not meant to say one drug is better than another. And I think that there have been some meta-analyses that have kind of put all this together, no head-to-head trials that I'm aware of. But at the same time, this is in the context of treatment on-demand use to achieve an erection response. Okay, this is not necessarily rehab. The idea of rehab, I think, is really almost a matter of discussion, is how we define that. Penile rehabilitation, if we use the strict term of recovering natural, spontaneous erections unassisted by therapy, that's rehab. But rehab also means supporting the patient and helping them with the recovery process and offering therapies by which they can be functional. So I think we have to tease apart a little bit about what that is. I just put here on this one slide what are the often referred to randomized controlled trials. Okay, some of you may be familiar with these trials, the Podman-Nathan trial at the top, the Reinvent trial with vardenafil, the React trial, tadalafil, and then Christian Pavlovich doing his independent trial. And you can see that some suggestion of potential benefit, but still a lot of controversy here. And for the brevity of this talk, this could be a talk in and of itself. Certainly this afternoon we can field more questions on this sort of topic if you wish, but I just wanted to put that up there just to say that we acknowledge that what these trials have been offered and that our field has tried to assess is there a role for PDE5 inhibitor therapy in the rehabilitative context of some sort of regimen of therapy that can help enhance natural function recovery. And here is the statements here from the ICSM and certainly a Cochrane database that supports the conclusion here that data are conflicting as to whether penile rehabilitation with PDE5 inhibitors improves recovery of spontaneous erections. Data are inadequate to support any specific regimen as optimal for penile rehabilitation. So I think we're saying right now that we don't have really great evidence to say that routine use of PDE5 inhibitors by many protocols out there are really successful in achieving a level of recovery. And so I anticipate we'll have some discussion this afternoon on this, but this is at least where the literature stands on this topic. So how to proceed? What can be offered that works? How can we meet patient expectations? We've said that term a number of times already. Where can we go forward here with established therapies that have efficacy? What do I do? Well, much of it is setting expectations. And I try to individualize approaches with patients, trying to understand their goals, recognizing that indeed all patients, I think, on some level would like to be as functional as they can be. But at the same time, we try to understand how patients want to proceed. Coaching and counseling, I do radical prostatectomies as well as the other side of it, which is helping men recover. And so I do a lot of follow-up. And I think that one of the challenges we face in our field is we have urologists on this side do the surgeries, they'll do the follow-up. We have others who do the follow-up but never do the surgery. That's challenging, I think, right? Because, we need to make sure that the full discussion is there for the patients. Toward the bottom are clinical trials, okay, which I think is the direction that I've always touted here, that we need to really continue to do good work in the field, do good work, and see whether we can actually bring forward studies at the preclinical level and then clinical level to really move the field forward. And if we think we're doing something that really has modest benefit or no real benefit, we're fooling ourselves, and we're doing a miscarriage of care to our patients without good, true therapy that makes a difference. So we got to really move the field forward with good work. Now this is a hard-to-read slide here that I put in a chapter for John Mulhall's book. John, remember I did a chapter for you for your book on where we are with nerve protection and nerve regeneration strategies. And this just makes the point that there are a host of agents out there that may have potential benefit. We heard this morning already about testosterone. Okay, so certainly that would fit within anti-inflammatory agents that may have potential benefit at various levels, tissue health, but as well as almost being neurotrophic, helping nerves preserve function. There are a whole host of other therapies that we think may be available, antioxidants, immune modulators, immunophilin ligands we studied, and other groups have studied. John's group has studied. We have not seen benefit from those, even though we had a lot of excitement with that with preclinical studies 10 to 15 years ago. Various kinds of other agents. The ones that we're very excited about lately now is erythropoietin that we've been studying over the past 10 years. Okay, and I'm going to tell you about how we've evolved with this. Erythropoietin, you're like, wait a second, erythropoietin, isn't that a drug that helps with your hematopoiesis? Well, indeed, it's a potent neurotrophic agent, and we're bringing it to this context as well. So this just opens the thought here. There's potentially a range of therapies that might afford us neuroprotection. Neuroregeneration, okay? And so I'm going to leave this slide up for a moment as you kind of look it over as well. We think of various neurotrophic factors. They're classic neurotrophins, but there are a whole host of atypical ones, and we're studying some of these. You heard about sonic hedgehog protein yesterday from Dr. Schindel. Various other growth factors that have been studied in preclinical models that are very interesting. Here, the idea of axonal outgrowth inhibitory neutralizers. If you think about how our nerves regenerate, even nerve development, there's agents that stop nerve growth. If we didn't, we'd all turn into nerve balls. All right, so there have to be agents that maybe we can exploit to really stop some of the inhibitory substance and promote nerve regeneration. That's what this is all about. So I think this is very exciting to think about this potential in the future with various studies as well. Various sorts of axonal reconstructive substances, various agents we can put into the pelvis potentially as nerve guides, fusogens, various other kinds of agents that can be engineered or stem cells. So this is all fruitful ideas that I think can be studied, all right, but we still need to study these and see if we can bring them forward. There's ideas for nerve stimulation, which I think is also very exciting here on a couple different levels, which I'm going to touch on in just a moment. I do think clinical trial investigation is key. Okay, we need to understand how these different agents potentially work and bring about good clinical work. John, your group published a good study on FK506, showed no benefit. That's an important publication. We did not see benefit with some of the true immunofilin ligands that we studied several years before as well. So we got to move forward. We did no benefit. That's good. Move forward. Steroids, no real benefit. Stem cells, the various trials in progress. I think you heard from Ryan Terlecky's presentation yesterday that there are a couple post-radical trials with just a few patients here and there. I'm aware of some other investigators doing some trials. So let's keep, we'll keep open minds and see where that might go. Erythropoietin is an exciting agent that we've been studying for 10 years. So this is an agent that's hematopoietic, okay, helps with your blood generation, but it actually is a potent neurotrophic agent. And we study this in preclinical rat models, and what we think is the mechanism behind that is it actually drives through an erythropoietin receptor in nerves through intracellular mediators at the cellular level, driving brain-derived neurotrophic factor that helps with nerve regeneration and growth. So there's studies behind this on a molecular level that have supported this. And of course, we did an initial study, a retrospective analysis on patients that I did surgeries on back in the late 2000s who got on the drug, and we saw retrospectively, obviously a flawed study, retrospective, that they knowingly were on agents, but we tried to match patients, and it did seem that there was some potential benefit. We did move forward with a trial now that we're almost finishing up now. And it's taken, this just tells you how much effort it is to do these trials. It takes several years. And these are not small business to do. This one we actually started about 7-8 years ago, had a halt because of concerns by the FDA with thromboembolic events. We showed that this was not likely to be the problem, and we were doing low dosing and restricted use, not chronic dosing, had to overcome all these hurdles and reinitiated the trial. And now long-term follow-up has been done, and we're trying to accrue the data, and I hope to be able to present this for the public within a year as to patients randomized in a controlled fashion to erythropoietin or placebo. Do they derive benefit in the radical prostatectomy setting? Electrical stimulation is exciting. Many groups have been involved with this. This is a study that we did several years ago that did show that we did achieve in 6 out of 12 men intraoperatively when I did radical prostatectomies and neurostimulators, I could elicit penile circumference changes. Now, of course, the challenge with all these nerve stimulation experiments is where do we think the nerves are and where are they exactly, and are they variable in different patients? More nerve mapping studies is really what's key, I think, to get some success in this area, and that's currently what we're doing now, and so we have some trials going on with that, because I think that we may need patient by patient intraoperatively to know where we're putting nerve guides, nerve fusogens, other agents in the pelvis, and so forth. Patient by patient, I think this could be beneficial in addition to doing the nerve sparing. This is meant to tell you that we're doing a current study with rats, and we're going to present this at the upcoming ICSM meeting in a few weeks in Slovenia, where we actually have put implantable electrodes in the rat pelvis, did nerve injuries, came back later and show with erection tracings, and this is what this is meant to show here with graphic, some histogram bars. The point is that we actually can put these nerve stimulators in, turn on the stimulator, it's inside the animal, and it can make the nerves, just by nerve stimulation, heal, regrow, and you can study the animals later and they recover natural function. So if we can do these nerve stimulators implantable in humans, post-radical, this is where we're going with this concept, maybe we're going to help patients recover their function. So stay tuned. This is going to be some exciting work, I think, for the future as we move forward. So the point here is there are many different future directions to go in. There are agents out there that are both neuroprotective and nerve regenerative. I think we can exploit these. We need to study these well on a preclinical level, move them forward to a clinical level. These trials and studies are not easy, but if they're meaningful, you do them well, and we learn something from them. So I think there are a whole host of options out there. You can see from nerve guides, nerve stimulators, stem cells and gene therapy. All these things are potential directions for the future, and I think it's bright. We just need to carry out more direction in the field to bring them forward for our patients. So by way of conclusion, autonomic nerve functional reconstitution, I think, is something we can develop. We need to elucidate this and evaluate it. I think despite our surgical modifications in the field, we need to bring about new therapies and study them well. And I think that this requires good preclinical work as well as clinical work to bring this field forward. So I will stop there, and again, I appreciate your attention. Thank you.